fatigue and weight problems. Inspiring, motivating, and guiding change. My name is Ray Chen. I am a Matthew Flinders Professor of Cancer Nursing, the Director of Caring Futures Institute here in Flinders University. I'm also the Chair of the Survivorship Group as part of COSA. I would like to take the opportunity to acknowledge the Victorian Government for funding this webinar, developed in collaboration with the Australian Cancer Survivorship Centre, Cancer Council Victoria, Cancer Nursing Society of Australia, and Clinical Oncology Society of Australia. I would like to begin by acknowledging that I am hosting this meeting from the Kaurna country. I acknowledge the traditional owners of the land on which we all gather today and honour their elders past, present, and emerging, and also any Aboriginal people who are here with us today in this webinar. This webinar recognises the expert skills allied health and nurses bring to the critical role they play in the care of cancer survivors. Within this webinar, our expert panel hope to shed light on making healthy behavioural changes within the context of cancer survivorship, with a focus particularly on weight management and physical activity. We know that behavioural change is challenging for all. It is even more difficult under the weight of a cancer diagnosis. Our role as health professionals is to help patients overcome these challenges to create behavioural change. As one of the key ways to do that would be via motivational interviewing, which will be one of our focuses and scope of today's webinar. So in this webinar, we'll discuss motivation, which is integral for behavioral change, and discuss how professionals can adopt practical steps to facilitate this change by engaging survivors through motivational interviewing, and also utilization of referral pathways that are available to us all. We will have a couple of short presentations followed by a facilitated discussion with the expert panel, and we will also be doing some role play, which will be quite exciting. And towards the end, we would like to make sure that we will give you an opportunity to ask questions and for the panel to respond to some of these questions. I will now ask all of our panelists to turn on the camera so they can introduce themselves to you. And I'll be asking them to take turns to introduce themselves. And first of all, David.
Hey y'all, my name's David Mizrahi. I'm dialing in from Pennsylvania in the US. I am an exercise physiologist and I work at the University of Sydney. I'm a research fellow there. I'm the chair of the Exercise and Cancer Council at COSA, and I'm currently doing a Fulbright fellowship at St. Jude's Children's Hospital in Memphis, Tennessee. Thank you.
Thank you, David. Jane.
Hi, everyone. My name is Jane Stewart. I'm the clinical lead dietitian at Peter MacCallum Cancer Centre in Melbourne.
Thank you, Jane. Clem.
Oh, hi, everyone. Yes, my name's Clem Byard. I am a nurse that works on the 131120 Cancer Information and Support Service at Cancer Council Victoria. I've previously worked at Peter Mac and at the Centre for Palliative Care, and I've got a background working in supportive care, research, survivorship, telehealth, and improving nurse-patient communications.
Thank you, Clem. And most important of all, we would like to welcome Paul. Paul, would you like to introduce yourself?
Yeah, hello, everyone. I'm Paul Malouf. I'm a consumer and a person living with brain cancer. So thank you for letting me be a part of this and sharing my story.
Thank you, Paul. Well, we would love to hear your questions and comments throughout the webinar and hope to make this as interactive as possible. So we encourage you to write down any questions that you have using the Q&A function. So once again, please do not use the comment function, use the Q&A function below. And we'll try our very best to get to that, especially towards the end of the webinar. Now, first of all, we would like to pass this time to Paul, who will be sharing with us his story, and we hope that we can actually expand on that a little bit more throughout the rest of the webinar. And I would just like to thank the panelists who can now turn on their cameras. I mean off, sorry. Take it away, Paul.
Okay, thank you. Thank you, Ray. Hello, everyone. Thank you for letting me share my story and being part of this webinar today. I think this discussion will make a significant impact on people's lives who are dealing with this disease. And just a side note, I'd like to thank all the health professionals and everybody involved with this discussion. A lot of healthcare professionals, especially in these current times, don't get the thanks or the credit they deserve. And from me personally to you, I'd like to thank you, and I'd like to thank you all on behalf of people like myself. So thank you. It will make a difference. I'm 54 years old and I live in a regional part of Victoria. It's a small coastal town, a couple of hours outside of metropolitan Melbourne, with my partner Frances and my 12-year-old daughter. Frances has had her own cancer journey, being diagnosed with breast cancer in 2013. We've been able to support each other through our cancer experiences. I joined Victoria Police in 2005 and love being a part of it. Being a police officer made me grow as a person in many ways, and I believe gave me the mental and physical toughness. It was a rewarding but very challenging career, often working by yourself and having to rely on your inner strength and judgment when things got tough. These skills helped me to deal with the life-changing event that I had no idea I was soon about to face. Christmas Day 2016. I was fortunate not to be working that day, and I spent the day with my family, enjoying everything that Christmas Day brings. Mid-afternoon, whilst walking out into the backyard, I suddenly collapsed onto the ground, losing all the feeling in the right side of my body. I experienced multiple painful seizures down the right side and lost feeling in the right side of my body. Sorry, I experienced multiple painful seizures down the right side and my right foot bending at odd angles and turning a dark red colour at the same time. The pain was extremely intense and I was fully conscious throughout this ordeal. I was unable to walk back to the house, so I dragged myself back to the back door, where Fran found me in severe pain as the seizures continued. I had no idea what had just happened to me, and it was a terrifying experience at the time. I was taken to the local hospital where I was seen by several doctors. After being kept in overnight and having these episodes in the presence of several doctors, they still could not determine what the problem was, and I was sent home the following day without being diagnosed. My seizures continued, and in this time span of about 2 weeks, and on the insistence of Fran, because me being a man, I thought it was nothing to worry about, I saw several more health professionals. Eventually, I saw a GP who immediately sent me for a CT scan on my head, which revealed an egg-sized tumour in the left-hand side motor cortex of my brain. After a subsequent MRI scan, I was diagnosed with a low-grade inoperable tumour. We sought a second opinion by an expert neurosurgeon. She was confident she could operate and remove as much tumour as she could. She told me I would have to be awake for the operation, which was frightening. However, I went ahead with it. I was told about possible side effects, including that I may suffer permanent nerve damage to my right leg, but that was a risk I was willing to take. In February 2017, I underwent a 5-hour awake craniotomy. So I've ticked that off the bucket list, the old awake brain surgery, so I wouldn't recommend it, but quite a unique experience, I must say. That resulted in the removal of approximately 60 to 70% of what was to be a malignant, diffuse, intrinsic grade 2 astrocytoma. It's a bit of a mouthful. The tumour was located in my motor cortex, which affected the right side of my body, mainly my right leg, resulting in loss of muscle size, strength and coordination. Recovery was slow. I had to learn to walk again, which took several weeks and months. Living in a rural area made accessing support services difficult. I was not given any information about how my treatment would affect me or about diet or exercise. I did my own research which in the end was confusing and conflicting, as I didn't know good information from not so good. Dr. Google, if you want to call it that. After surgery, I had to take steroids to reduce any brain swelling. Not only did these make me feel sick, they made me gain weight. I was determined to recover as best I could so I could get back into leading a normal life, well, somewhat normal, although it being a little different. I took it upon myself to do my own rehab to try and get back some of my strength. For example, after surgery, I had to sit down for showering because I could not stand, otherwise I would fall down. But eventually, by going to the gym and exercising to strengthen my right leg, things began to slowly improve. Mid-2017, I underwent 5 weeks of radiotherapy, and in October of the same year, I started 6 months of chemotherapy, which I completed in April 2018. During radiotherapy, I noticed increasing fatigue, which worsened each week and made it very difficult to walk even the length of a street block, without me having to stop for an extended period, allowing me to rest and catch my breath so I could continue on. Dealing with this fatigue had affected my appetite and any real willingness to exercise, which was new for me. So I just love to exercise and I love going to the gym. I'd lost virtually all motivation and just wanted to sleep, and even sleeping was very difficult. Eating and drinking certain types of food made me nauseous, even to the point of nearly passing out. My weight fluctuated up and down, and I really didn't know what to do or who to turn to for assistance. I knew I needed to exercise, however, lacked the support to do so. I had to work out myself which foods were making me feel sick. If support was offered, it would have been so much easier, not only for my recovery, but also to help deal with my diagnosis. There are a host of other inconvenient side effects of treatment that are permanent, but that's okay. It is what it is, and it's a small price to pay for being able to live a little longer. My right leg feels numb, and I've lost a lot of strength, some feeling and coordination. Extreme fatigue is ongoing. There are cognitive and mental health issues as well. There are bouts of depression, uncontrolled mood swings, and memory loss. I was never much good at multitasking, but it's even harder now. I can't make a cup of coffee and have a conversation. It's just too hard to do both. I've tinnitus now and balance issues and vertigo. My eyesight has worsened, hence why I'm wearing the old glasses. There's been a loss of appetite, weight gain, as well as weight loss. I'm back in the workforce now, working 2 days per week, teaching children with special needs. Whilst this being rewarding, it's taking its toll on me in every way now, and I plan to leave in the very near future, as it's a struggle sometimes just to get through an ordinary day. Some days are okay. I think, yeah, I'm smashing it. I think I'm going okay. But there are other days that are overwhelming and I struggle. Now, people say, oh, but you look okay. Yeah, well, I guess I do, but what does someone with incurable brain cancer look like? There's so much more that you cannot see. As a result of all this, that's what's happened to me. I was forced to retire from a career as a police officer due to my diagnosis and my initial seizures. I'm doing okay now, and exercise and train according to how I feel, which I find very important. Sometimes overdoing it is actually worse. I listen to my body and I try to exercise smarter, not harder. I currently undergo 6 monthly MRI scans, and so far the remaining amount of tumour is deemed as being stable, which I hope continues for a long time to come. Scanxiety, I don't know if you've heard that terminology, but it's quite real in the brain tumour world. Scanxiety is a real thing, and that is what we live by, our results. When I hear stable, I put that in exclamation marks, quotation marks, and no progression from my oncologist, it's happy days. Woohoo, until the next scan. Moving from scan to scan isn't ideal, but that's the way it is, and it always will be that way. Being diagnosed with this disease has taught me a great deal and changed me in many ways, some good and some not so good. It's just the way it is. The love, understanding and support from my family and friends has been invaluable in my recovery. A change is expected at some stage along the way. That's just the way it is. It's just a matter of when, and I know it won't be favourable. That's the nature of my tumour. So until then, I try to live life, and I will deal with the bad news when it happens. And just finishing off on that, I just wanted to clarify that my experience with all the health professionals I've dealt with after my diagnosis and treatment has been absolutely amazing. So I just want to say that. So thank you.
Thank you, Paul, for sharing with us your story. And there's so many things in there that really resonate with many of us here who are in the room, and we look forward to unpacking it a little bit more with you, especially in the context around how we can support people in the self-management, but also in facing fatigue and weight problems, as highlighted by yourself to be some of the key issues that you had to deal with. So right now, I'm just going to refer to David. We have got two experts, David and Jane, who will be sharing with us a little bit about their thoughts from the discipline knowledge around some of the issues that Paul has raised here. Thank you, David.
Thank you, Ray, and thank you, Paul, for sharing your story. Lynn, if you jump to the next slide, please. So as we know, a lot of the health professionals here, there are a myriad of health consequences as a result of different type of treatments that we know cancer survivors can receive. And we know that these changes are going to happen. And the two that we're going to focus on today are changes in body composition and also fatigue. Next slide, please. And one of the things that we're focusing on is weight issues. So most patients, or a lot of patients, will receive chemotherapy, in particular radiation therapy and hormone therapies that will interact with people's body composition in addition to lifestyle changes. And this is a real and common issue. And, you know, we know that other downstream effects like cardiovascular disease can occur. So it's something that we really want to focus on in survivorship. But on the flip side, we also have weight loss and muscle loss, and that can be really important. And next slide, we see that fatigue is one of the most common issues, both during treatment for patients, but also after treatment. It can persist for months or even years after treatment. And this is a really important and debilitating symptom when you're talking about exercise for someone who's never exercised and is really fatigued. It's a really important barrier to overcome. Next slide, please. And, you know, in Australia, we're really fortunate in the position that we have endorsement and support for the role of exercise in cancer care, that COSA has come out and supported that, you know, exercise should be discussed in terms of cancer care and survivorship, that patients should be recommended to strive towards the guidelines, and at least start with something is better than nothing, and slowly move up towards those guidelines. And for patients who are in need for extra support to at least get started, to be referred to health professionals with exercise prescription skills like exercise physiologists and physiotherapists. Next slide, please. So very briefly, you know, a lot of you are here are health professionals in this space, but it'd be good to just be aware of what's going on. So a quick poll question, it will pop up. Do you know which health professionals are involved with activating the chronic disease management plan for cancer survivors to activate Medicare rebated sessions with health professionals like exercise physiologists? So please click, just be up for 5 seconds or so. Then you can select it. Am I in charge here? Don't know. How long do we have here, Lynn? Hopefully we get the poll up. Great. So most of you got it. And there's a few that have clicked anyone from the treating team or medical oncologist. And critically, only the GP can activate this care plan. And this is another barrier. You know, a lot of patients won't see their GP for 6 months or so while they're receiving cancer treatment. And unfortunately, the medical oncologist or other clinician team from the cancer team can't activate care plans, has to be referred through the GP. So it's an additional barrier, but it's a worthwhile barrier to activate allied health support. Next slide, please. So what's really important in terms of getting people started, particularly if they've done exercise before and they've lost a lot of physical function and don't know where to start again, or people with no exercise history, is to get them to extra additional support in terms of EPs or physiotherapists who can get these patients started with individualized exercise programs. Or if they want diet or physio support as well, they can access these services. If they have diabetes, they can get an extra 8 sessions with an exercise physiologist. They might have private health cover as well that can support extra sessions. So it's really important to have this conversation with patients and their doctors if this is something they're willing to do. And they can find an exercise physiologist on the ESSA website over here. In terms of fatigue or exercise prescription, during treatment or even after treatment, I think it's really important to monitor how symptoms might fluctuate over time. So particularly during treatment with different chemotherapy cycles, we know we're going to get a symptom burden for the week or so after treatment, and this might relinquish over the next few weeks. So we might end up having 2 different exercise programs. When a patient is feeling really good, we can start to do the higher intensity, more minutes, higher dose. But if they're feeling really crummy, we might not want to say no exercise at all, but maybe just a 5-minute walk or a very light intensity version of what we did. So having 2 different programs around symptoms, I think, is really important. In terms of the role of exercise and fatigue, we're seeing more and more clinical trials that are supporting that exercise is actually beneficial in reducing fatigue. And this is critically really important, particularly for someone who is going during treatment or after treatment and is a non-exerciser and has a lot of fatigue. This is a really important motivational, educational opportunity that exercise will actually reduce this fatigue. And it's a hard barrier to overcome. So I think as a medical team working with a patient when they're about to get treatment, if we can educate them early on that they're probably going to get fatigue, if they're active, they might be able to mitigate this as well, is really important. And in terms of weight gain, we know that, like I mentioned earlier, there's so many issues that are leading to weight gain. So we might need to strive towards the physical activity guidelines or even a higher dose. Some papers have come out and stated the role of resistance training is really important for metabolic control, but critically in conjunction with a healthy diet and perhaps reducing things like alcohol intake, and not just the benefits of weight loss if there's weight gain. There's all these other downstream benefits like hormone regulation, metabolic effects that are going to benefit the patient, as well as psychosocial and quality of life benefits from hitting these targets. And on the flip side, if we have patients with weight loss or sarcopenia, that's a really, I guess, big issue for people who are losing muscle mass, losing functional capacity and ability to do things that they love, and that can also have quality of life issues. So for those kind of patients, it's really important to try and preserve or increase their muscle mass so they can be able to improve their functional capacity and do the things that they enjoy and get their quality of life back. I think that's really quite critical. So linking it all together is the theme of the day, and that is motivational interviewing. It's a really complex thing, behavior change, working with patients. Like they're trying to save their lives here with cancer treatment, but we're seeing more and more the role of exercise in cancer care, that it is a medicine that can assist in so many different ways, but we need to coach about behavior change. And the aim is sustainability, that patients can have good, healthy behavior change where they can continue this lifelong healthy behavior. So we need to discuss good questions about what exercise they like, what are the barriers, what are their symptoms, can we set goals, can we educate, can we have iterative programming around their symptoms and activity pacing around their fatigue, for example? Can we have empathy and respect when they're having bad days? Can we act collaboratively with them and their health team? And can we assess when they're ready to take things on by themselves? And that's really about trying to get them to find their intrinsic motivation. But in and around, we need to schedule this in around their work and their family commitments, their clinical appointments, the other barriers that they have to exercise, like time and money, and their exercise experience and enjoyment, as well as their symptoms. So there's a lot of different components going on that we need to work around with to ensure that patients can enjoy the type of exercise that you're prescribing, so they're going to continue to do it as they go through their journey. that's it from me now. So thank you.
Great, thank you, David. Thank you for sharing with us your insights. And next we have got Jane, who will be speaking to us a little bit more specifically around the role of diet in managing some of these issues. So thank you, Jane.
Thanks, Ray. So as David just mentioned, cancer survivors can experience a whole spectrum of nutrition issues that can lead to both unintentional weight loss or unintentional weight gain. Malnutrition, sarcopenia, and cachexia are common and can occur in patients of any weight. Malnutrition is present in 30 to 40% of people with cancer. Sarcopenia occurs in approximately 60%, and it has been estimated that cancer cachexia affects between 50 to 80% of patients with cancer. So as highlighted in the COSA position statement on cancer-related malnutrition and sarcopenia, it is important that all patients with cancer are screened for malnutrition and sarcopenia, regardless of their weight. Screening should occur at diagnosis and as the clinical situation changes. So for example, when they move from surgery and when they start chemotherapy or radiotherapy. So it's as the clinical situation changes, then patients should be re-screened. All patients identified at risk via screening should have a comprehensive assessment of nutrition status and or muscle mass. Next slide, please. On completion of treatment and transition to survivorship, it is important that patients are advised to make the change from a high-energy, high-protein diet, which is often used to prevent weight loss during treatment, to a healthy, balanced diet. Nutrition recommendations for cancer survivors are the same for cancer prevention. So patients should aim to be a healthy weight, so to keep weight within a healthy range and avoid gaining weight during their adult life. They should be physically active in everyday life, eat a largely plant-based diet rich in whole grains, vegetables, fruit, and beans, limit red meat and avoid processed meat, limit processed foods high in fat, salt, and sugar, limit sugar-sweetened drinks and alcohol, and avoid the use of supplements for cancer prevention. So why should we encourage cancer survivors to keep within a healthy weight range? Studies suggest that up to 70% of cancer survivors are overweight or obese, and being overweight can increase the risk of 13 different types of cancer, as well as increase the risk of other chronic diseases such as diabetes, cardiovascular disease, stroke, and chronic kidney disease. Being overweight has also been associated with reduced quality of life and increased risk of functional decline. Cancer survivors should aim for a healthy weight range, so a BMI between 18.5 and 25. And they also should really avoid or aim to avoid central adiposity, which is a sign of increased visceral fat and is most linked to increased risk of chronic disease. So patients should aim for a waist circumference less than 80 centimetres if they're a woman or less than 94 centimetres if they're male. It's also really important to consider muscle mass. So sarcopenic obesity is increasingly more common and can have negative impacts on both function and clinical outcomes. So now we've got another poll question. So whose responsibility is it to talk to cancer survivors about achieving a healthy body weight? Just wait for the responses. Great. That's the answer that we're looking for. So ideally, we want all cancer clinicians to talk to patients about their weight. Next slide, please. Great. So we know that diets don't work, and many patients who lose weight regain that weight. A systematic review of maintenance of weight loss after lifestyle interventions for overweight and obesity found that 50% of weight lost was regained after 1 year. So rather than focus on weight, it can be more helpful to focus on diet quality, non-hunger driven eating patterns such as comfort eating, and an increase in physical activity. Unfortunately, acute cancer dietitians don't get to see all patients with cancer, and often don't have the capacity to support patients who want or need to lose weight. All cancer clinicians can play a role in motivating cancer survivors to make positive lifestyle changes. So ideally, we'd like you to target your education to motivate change. If we look at the stages of change model, we're aiming to move patients from the pre-contemplation phase through to contemplation, preparation, or action stages. Clem will talk about this a little bit more later, but we can use change talk as a way of identifying which stage of change a patient is at. If your patient says, I could do X, Y, or Z, they're probably in the contemplation phase. If they start using stronger statements like I should or I need to, they're moving through the preparation stages towards taking action. And if they make statements such as I will, then that sort of talk is strongly associated with people actually taking action. So if you can work with your patients to set small achievable goals and then refer them onto the appropriate services. When goal setting with your patients, last slide, it's good to one, find out what the patient already knows. And then two, if you can manage the conversation so that patients end up proactively asking you for information so that they can make a plan for themselves, it is likely to be more powerful than you giving them one information that's one size fits all. Next slide, thanks. So the Can-Eat model of cancer nutrition suggests that we can take a risk-stratified approach to nutrition care and aligns with the COSA model of cancer survivorship. So in this model, some people with cancer will have complex needs and will require assessment and intervention by a specialist cancer dietitian. Many people will need access to a dietitian, but this may be in the community or primary care setting. And there will be a large cohort of patients with cancer who can self-manage with access to appropriate information. So as mentioned in the previous slide, some patients with complex needs will be best managed by a multidisciplinary team within an acute cancer centre. But there will be a large number of patients who can be referred on to clinicians in primary care and community settings. So this could include a rehabilitation setting such as cancer rehabilitation or community rehab, community health, which offers a multidisciplinary team approach, and clinicians are often trained in health coaching for chronic disease management, or in private practice where patients can utilise a chronic disease management plan and team care arrangement with a dietitian, physio or EP. And then there will also be a cohort of patients of cancer survivors who can self-manage with access to appropriate resources. There are a number of resources listed here, which will also be included in a resource list that will be shared after the webinar today. Thank you.
Thank you, Jane, for giving us the context, and thank you to the both of you, David and Jane. And for now, what we might do is to get the panel on screen, the entire panel on screen, as we explore a little bit more about the roles of health professionals in supporting patients to self-manage some of these issues. And we've got Jane, David, Clem, and Paul on the screen. So what I recall is watching some of these presentations. A few years ago, we did this study going to the waiting room, talking to our patients who have completed treatment, active treatment, and we surveyed them about how often they actually experience some of these symptoms. And certainly with fatigue, we have 66% of people who have finished treatment experiencing some level of fatigue. And of those 66%, half of them, which is around 33% of the entire cohort, reporting moderate to severe fatigue. So it is definitely huge. It is an important issue that our patients face, and certainly weight problems is also a key issue as well experienced by our patients. So just in relation to fatigue, it is a question I want to target at you, David. It is oftentimes an issue that is underreported, under-recognized. Patients don't feel that we can do something about it. How can health professionals discuss the impact and management of fatigue in our routine consultation and make it really part of our care pathways? What are your thoughts?
Yeah, thanks, Ray. It's such an important symptom, I think, to address from all health professionals, from medical, nursing, and allied health, because we do know that it can be really debilitating. And this is really important for people who want to go back to work or interact with their families or just do the things that they enjoy. So I think having the awareness and the conversation that it is, very possible that it could happen, at least gives patients, they're going to prepare for it. But I think it's important to have the conversation that there are strategies to minimize this, and something like exercise, even starting with something simple, can help to reduce the onset of this. And as I mentioned in my presentation, it might fluctuate during treatment or after treatment, where normal daily tasks might exacerbate the symptoms and might make the fatigue worse. So I think it's really critical to, if you're going to be working with patients, to find what's the sort of sweet spot with the amount of activity that you can do. And as Paul said in his speech, that sometimes he did overcook things and overdo things, and then he crashed. So it's important to find what the limits are and sort of strive towards them, and not overdo it, and slowly be able to work up over time.
Thank you, David. Paul, from a patient's perspective, a lot of the research literature and research studies have been telling us that patients actually rate fatigue as one of the most distressing symptoms. And oftentimes, health professionals don't necessarily realize that. Perhaps can you comment a little bit on that, around how you feel health professionals are placing an importance on fatigue from a patient's perspective?
Fatigue, it's a big deal, because I think everything, if you want to put it that way, stems from fatigue. If overwhelmed with fatigue, that's all you can sort of focus on. And I think it's a big part of someone dealing with cancer. Fatigue, if you're suffering from severe fatigue, you lack the motivation to exercise. It affects your diet. It affects every aspect of your life, and sometimes even making an appointment because you're so fatigued. Even just going to see your specialist, and when you're struggling with the fatigue, even that in itself is a huge thing. So I think this discussion today, I think it's extremely important, and like you say, the fatigue for cancer patients is a major hurdle.
Yeah, Paul, many patients have been telling us that sometimes the reason for them not to want to exercise is fatigue itself. So it becomes a little bit of a vicious cycle, and certainly it is something that exercise professionals are dealing with every day, when patients come to them and actually said, well, I know that to combat fatigue or alleviate fatigue, I need to exercise, but that is the very reason that I cannot get active or exercise. What are your thoughts about that? Has it been a barrier for yourself?
It was a barrier, especially with my right leg. It was very difficult to still have issues now, actually, but with my struggling to walk, my coordination, my strength, those sorts of things, that was a huge barrier. Living where I live in a regional setting, that was another barrier in itself. I don't think people in a regional area tend not to have maybe the facilities or those sort of things to help them. If you're fatigued, the last thing most people will be thinking of is, I'm too tired, I don't want to exercise. That's the last thing I want to do. That's very difficult, and feeling nauseous and all the side effects, they're all contributing factors. So that makes it extremely difficult.
Yeah. And I'll jump in. I think one really important conversation to have with patients and survivors is, in terms of expectations of exercise, is, it's a hard conversation, but this is kind of the new normal for the moment. So, and being comfortable with this change is, I think, really important in changing behavior. And, we don't have to do a 90-minute CrossFit session. It's something just like 5 minutes. Like, let's try 4 squats or something in a chair, or 3 minutes around the block, or up and down a step for 1 minute. And I think that can be the barrier, because people are thinking, I have to do exercise. The doctor said exercise. And they're thinking that anxiety about, a whole session of exercise is a big deal. But if we can just start with just anything, just the slightest bit, even in bed, like some band exercises in bed, and that, you know, that might be challenging for you for the moment. So that counts as exercise, and that's really great to start with something. I think that's really important. And then we can slowly work up again from this new normal.
That is a very, very important pointer, David. So today's topic is really around motivation of people, and it is so good for us to reflect a little bit about Paul's background, being a very active policeman, you know, with that inner strength and toughness that he described it, which I really, really like. We see that there are patients who are very active, even pre their cancer diagnosis, and there are also people who haven't had experience or actually the motivation to exercise even prior to their cancer diagnosis. What would be your different approach, I guess, in talking to those two groups of people, or actually people who are in between? How would you do that, David?
Yeah, it's such two different populations. Like, I find people like Paul, it's probably easier to work with because he has the history of exercise. He enjoys it. Like, he knows the benefits. It makes him feel good normally. So getting back into it has its challenges, that it's the new normal and the expectation is going to be totally different. So in terms of that education, that's what we're going for. You know, it's going to feel like a very basic program to him, especially with his leg issues as well. We have to make it basic just to rebuild and get back up again. And that might feel strange for the first few weeks, but that's just what we have to do.
Yeah.
For someone who doesn't have an exercise history, it's totally different. We really need to find what they enjoy. There's no point in saying, let's do some cycling if they hate cycling so much. You know, I think anything is better than nothing just to get started. So a good, motivational conversation with them about what might bring them joy, or let's try different types of exercises. Giving different things a go might be important, especially in the first instance. Maybe starting with very low intensity exercise if they've got anxiety about starting. Something very basic, maybe doing some functional exercises. You know, if they want to get back to lifting up their grandchild again, you know, we can practice doing activities that replicate functional movements so they can, you know, strive towards something that they want to achieve when they're able to again.
Yeah, great. Thank you, David. And I might refer to Jane before I go to Clem, because Clem is our expert in motivational interviewing here, which is something that we're really going to ask him to unpack for us. But Jane, I think that sometimes we make assumptions about pre-diagnosis habits and actually the motivation level of the individual at this very moment. But certainly we have seen some teachable moments, and people all of a sudden, because of the cancer diagnosis, all of a sudden having a healthy boost or healthy dose of motivation. What do we do to capture those moments? What would be your advice for health professionals to capitalize on those moments, you think?
I mean, I certainly see a lot of the patients that I see who've been through cancer treatment are very motivated to make lifestyle changes, but they are probably the ones that perhaps seek us out, and we probably don't see the ones that are less motivated. But certainly capitalising on that motivation is really important, and working with patients if they are motivated to help improve their, you know, to make some behaviour changes to improve both their diet and their levels of physical activity is really important.
Yeah. Thank you, Jane. And I think towards the end of the webinar, I would really love to be able to go back to that, because sometimes those moments that people are the most I guess motivated is not necessarily the time that we are available to be able to get into the discussions. It'll be interesting to hear your thoughts about how we can really try to systematize our intervention as well, so patients don't miss out those moments whereby they have the motivation to change. Clem, today's topic is, we would like to really unpack motivational interviewing a little bit. Can you tell us what it is and actually tell us a little bit more about that?
Yeah, sure, Ray. Look, first I thought we might do another little poll just to get a bit of an idea from the audience how much they already know about motivational interviewing. So we might bring up that poll on the screen for a second, just so that we can pitch the discussion. So that'll just be up for a half a minute or a minute or so. How well would you rate your understanding of motivational interviewing? All right, so we'll just have that for a little more and hopefully the results will come up. All right, so there is some understanding there about it. That's great. All right, so firstly, a bit of a brief introduction to motivational interviewing. Motivational interviewing originally comes out of addiction treatment, but it's gradually been rolled out and used in lots of other kind of areas to help people with behavioural change. It's evidence-based, it's focused, and it's really focused in on, goals, achieving, individual goals. And it's, I suppose, we're sometimes confronted with, cases where patients, may have a knowledge deficit where we need to educate the patients, but motivational interviewing is really focused on times where this person probably knows what they need to do, or they know what they want to do, but they're having trouble motivating themselves to do it or to do it consistently. So you're going to come across some people who we were just talking about. Some people are going to be highly motivated and they might not need very much motivational interviewing. Okay, they're already motivating themselves. And you might come across some other people who are quite lowly motivated, but you're going to come across lots of patients in your clinical practice who are what we would call ambivalent. So they're in kind of two minds about behavioural change. They know, that it's really important for them to eat better or exercise more, lose weight for their health, but they've got some other factors that are kind of pulling against that. So it could be fatigue, like Paul was mentioning, and and there you've got that ambivalence. They're getting pulled in two directions and they're sort of left in the middle. And so motivational interviewing is really a way of trying to move them towards the, the take action, make behavioural change side of things. And I suppose a real core of motivational interviewing is, instead of like telling the patient what they should do, it's trying to engineer the conversation a little bit so that the patient themselves makes the arguments for change themselves, rather than us, the clinician, telling them what they should do.
Thank you, Clem. And I think you definitely have highlighted the difference between sort of the more traditional approaches that we tend to teach, prescribe. We have ordered certain things, and I think certainly in healthcare we have grown to realize that that is no longer the approach that we should actually keep going, especially when we want to optimize self-management. Now, Clem, we have talked to nurses and health professionals a lot, and we oftentimes find ourselves find it very, very hard to not tell people what to do as the health professionals. What are some of your advice about people who realize, health professionals who realize that they need to move a little bit more from the traditional approach towards the more motivational interviewing type of approach?
Yeah, thanks, Ray. I think that, that's exactly right what you say. So many of us as nurses and other, types of health professionals, we're really used to, coming into an interview with a patient and assessing the person for their needs and then providing them with solutions. And if there is a kind of knowledge deficit, that might be, a good way of proceeding. But if we're trying to motivate people and that person is ambivalent, it might actually be counterproductive to keep on telling them what they should do over and over. Because when people are in this state of ambivalence, if you come out and you tell them, what they should be doing, you give them lots of good advice, the natural thing for someone who's in two minds is to give voice to sort of the other side of the argument, if you will. And so they will, come out and say some of the things, the reasons that they cannot change. They cannot make behavior change. They can't do what, you're sort of advising them to do. So yes, motivational interviewing, it uses a lot of little techniques that, you know, lots of us use in conversation anyway, but just using them in a way to try and put the responsibility back to the patient. Yeah, and instead of giving them advice, drawing out of them what they want to do and their reasons for doing it. So it certainly has been tested in lots of different contexts now. It's been shown to be beneficial for lots of people in short-term and long-term behaviour change. And it's around sort of inspiring people and, you know, just gently guiding them towards the more change-orientated, you know, way of talking about themselves. And it's powerful because, you know, the research coming out of, you know, psychology and addiction management, and then lots of other contexts now, is that when people give voice to their intention to change, what Jane was talking about, that change talk, I want to do this, or I know I need to do this, or I could do this, or, you know, sort of most powerfully, I will do this. When people use that talk and say it over and again, it sort of reinforces in their own mind, you know, and is more correlated with people actually taking positive action. Yeah, and I guess motivational interviewing is a way of getting people to use that positive change talk, you know, more frequently, yeah, and just reinforcing it. So that's the basis of it.
Thank you, Clem. Now, when we first came together to talk about the purpose of this webinar, we never quite thought that we are going to run a 3-day workshop on motivational interviewing. But one of the measures of success is that we think that we will be very successful if people walking out or dialing out from this webinar thinking that I am going to get trained on motivational interviewing. I'm going to start putting some of these little nuggets into my practice, or I'm going to learn more. That would be a sign of success. Now, what we're going to do is we're going to get Clem to get you and Paul, and then yourself and Jane to show us how are they done in practice. So we're going to have 2 role play sessions, and I'm going to ask the panelists who are not involved in the role play, you can potentially get a little break, but we would love for you to inspire us how it is actually done in practice. So Clem and Paul.
Yeah, thanks, Ray. So we'll do a little couple of minutes. So in this scenario, I'm the health professional delivering some motivational interviewing, and Paul's playing himself and having some ambivalent thoughts about, you know, his ability to, you know, undertake more exercise. All right, are you ready, Paul?
Ready to go. We'll give it a crack.
Good. All right. Hi, Paul. I see that you've been referred to me because of the fatigue you've been experiencing. So from what you were telling me, it sounds like you know a fair few exercises and activities that you could be doing already from the Exercise and Sport Science Australia Exercise and Cancer ebook that we were looking at before. So tell me, have you been told, or do you know that regular exercise can actually help combat fatigue and increase your energy levels?
Yeah, hi, Clem. Yeah, I know, but unfortunately I can't do any exercise at the moment. You know, I'm just too tired. And to be honest, I've lost a bit of confidence. And when it comes to exercising, and because my right leg isn't too strong, it's a real struggle, you know, just to mow the front lawn, and that the front lawn's not that big. So, I mean, the idea of going back to the gym, there is no way I can even manage that at the moment.
So, Paul, it sounds like previously you enjoyed going to the gym. Is that right?
Yeah, that's right. Before I was diagnosed, I used to go to the gym pretty regularly, actually, and I actually trained the day before my surgery.
Well, that's great. So tell me, what was it about going to the gym that you liked?
I just love the feeling, you know, of being strong and healthy, and I miss that feeling. You know, I really enjoyed it, but it's just too hard at the moment.
So you'd like to get back into going to the gym so that you can start feeling physically fitter and stronger?
Yeah, I don't know. I haven't really thought about it at the moment. It's sort of a little bit overwhelming.
I mean, Paul, if you were going to come up with a plan for yourself, you know, as you were going to build up, you know, get your confidence back into going to the gym, what sort of things would you build into the plan?
Well, I could maybe sort of start off at home with some exercises, some basic exercises, maybe get some weights, and maybe that might help me feel a bit more energetic, I guess.
Yeah, well, that sounds great. When do you think you'd be able to start doing that?
I'll probably start tomorrow. I haven't got anything else planned.
Oh, that sounds great. All right, we'll just take a little time out of the conversation there, Paul. So I guess when I'm talking to Paul as a clinician and I'm hearing what he's saying, I hear multiple different cues or multiple different things in each, little group of things that Paul says, multiple different things that I can pick up there. Some of the things that Paul says are sort of more negative. So he might say, I feel too fatigued to exercise. Some of the things are more positive, more like the change talk that we were thinking about. So that he feels healthier when he exercises or things like that. So I, as the clinician, can choose which of the different cues that he gives me that I can pick up on and bounce back to him and sort of get him to expand on. And so part of motivational interviewing would be picking out the things in what the patient says that are more positive, picking up on those cues and getting those ones expanded on so that the conversation goes in a more positive and, more change-oriented direction. So those of you who might have studied communication skills, we might talk about those sort of things as active listening or reflective listening, sort of bouncing ideas back to the patient when they've said it. And another aspect that you might have picked up in that conversation with Paul is that I really tried to avoid me providing him with a plan or me providing him with too many solutions to his problems, because it's much more powerful when Paul or whoever the patient you're working with provides the plans, the solutions themselves. If they actually, make the plan and they say the plan out loud, they're much less likely to argue against it than if you've tried to, put a plan on them, even if it's the same plan. So yeah, I guess with motivational interviewing, we try and get the patient to, suggest what they'll do and then repeat it a few times if possible, so that it sort of reinforces the idea. Thanks, Ray.
Great, thank you, Clem, and thank you, Paul. Now we're going to do another role play, bringing Jane out, and we are going to try to focus this role play on managing weight problems. Thank you.
Good. All right.
Sorry, hi, Clem.
Hi, Jane. Now, so I suppose one of the things that I was hoping that we might be able to bring out in this role play is going a little bit around when you potentially have a patient who blocks all of your positive suggestions or things like that. I think that will be a scenario that is very familiar to lots of us that work in these kind of fields, where you've got like all these things, you've told them things, and every time you come up with some good suggestions for someone, they find a reason why they can't do it. So again, in this scenario, I'll be the motivational interviewer, and Jane, you're a patient who is being resistant to making dietary changes. All right. And I suppose one thing to also mention just before we get started is I think it's good to focus on one aspect of behaviour change. It's something that was picked up a little bit earlier on in the conversation. If you try and say, okay, we're going to do everything for a whole healthy lifestyle in one go, it's easy to overwhelm a patient. But if you can pick out one small feasible change, and it could be like increasing the number of serves of vegetables, then, that makes it much easier to work with. All right. So Jane, we'll start now. So Jane, we've been talking about the potential health benefits of increasing the amount of vegetables you eat. Are you now thinking about increasing how many serves of vegetables you eat?
No, not really. I don't really like vegetables and they don't fill me up.
Okay, so I guess, could you think of ways that you might be able to make vegetables taste nicer, or, so that you'd like eating them better?
I don't think so. I really don't have time to cook anyway. I usually just get takeout or eat out somewhere, and often the only vegetables they have on offer are potatoes. I have lots of other things to organise, and I'm not sure where I'd find the time to shop and prepare food.
Okay, so Jane, just to recap, it sounds like you might be able to, you kind of know that you might be able to improve your health if you did manage to eat more vegetables on a regular basis, but there are a few things that are making it difficult for you. Tell me, if you had to give me a number out of 10 on how important it is for you to eat a healthier diet over, say, the next fortnight, and if you could put a number on it, 1 is it's not important to you at all, and 10 is it's the most important thing to you, where would you put yourself on that scale?
That's a hard question. I suppose maybe a 5.
A 5. Okay. So Jane, tell me why you didn't rate the importance of eating a healthier diet over the next couple of weeks lower than a 5. You made it a 5, but you didn't say like a 2 or a 3.
Yeah, I don't know. I guess because I know that I need to eat more vegetables to get more fibre and for my long-term health.
To improve your long-term health. Yeah. Okay. Well, that's great. Can you think of any ways that you might be able to increase the amount of vegetables that you eat in the next fortnight? How might you be able to do it?
Well, I guess I could cut up some carrot sticks at morning tea time. I actually don't mind carrots too much. And maybe I could put some tomato in my toasted cheese sandwich.
All right. So we might step out of that conversation again. There's always a great temptation, and possibly that scenario might have sounded a little bit artificial, but there's always a great temptation when people don't provide their own solutions for us as health professionals to jump in at the first opportunity and give them a solution. But when I did give Jane a solution a little bit earlier in that conversation, like saying is there some way you could make them nicer, she blocked me a second time. So I guess motivational interviewing has included in it a bunch of little tips or tricks or things like that, where you can take a negative conversation and turn it round to more positive change talk. One of those could be summarizing the things that the patient said to you, like, so Jane, you've told me there's this problem and that problem and this reason you can't do anything. And then after you've done the summary, so now tell me about something more positive. Or another technique is the little example that we gave there, where getting Jane to rate her motivation out of 10. Now, when she said 5, I, as the clinician, would have had a choice. I could say, why didn't you rate that higher? Why didn't you rate that an 8 out of 10? Or I could say, why didn't you rate it lower? Why didn't you rate it a 2 out of 10? So if I asked her why she didn't rate it higher, her natural inclination would be to tell me all the problems that caused her not to rate it higher. If I say, why didn't you rate it lower? Her natural inclination will be to tell me the positive motivating factors. So there's just a range of different little ways that you can, once you get some experience using motivational interviewing, use it to guide the conversation more into the positive change talk direction.
Clem, there's just a question that's popped up. Any suggestions for patients who use yes or no answers?
So I think, yes, I think as you do more and more of this, you find a few different ways of doing that. I think one thing is using open questions. So deliberately asking questions in a way that make it difficult for people to give just a simple yes, no. Quite often I'll use phrases like, can you tell me a bit more about that? Or things like that to sort of draw out more if I feel like I haven't yet got enough to work with. And sometimes I will actually use a little bit of silence. I will sit with them. There's a great temptation on our behalf as health clinicians to jump in very efficiently and give lots of solutions and answers. But if you actually just sit with it and let the patient have a little bit more time and space, then often they will expand into that space and tell you more about what's going on for them and give you more to work with from a motivational interviewing point of view. So, yeah.
Thank you, Clem. Just looking at how you even demonstrated some of the questioning, I was sitting there thinking that, oh my God, these questions were all in the question list of the motivational interviewing classes. And I just thought it's absolutely brilliant to see you using that in practice. And thank you so much, Clem, for doing that for us today. Clem, where do people go for more sort of substantial sort of training and practices around motivational interviewing? Where do people go?
Well, sure, Ray. I guess when I first came across motivational interviewing, I was working at Peter Mac as a nurse, and I was one of the intervention nurses on a project. And so a lot of supportive care projects are starting to use motivational interviewing. And at that time, we went to, I think that was the Australian Psychological Society, and did 1 or 2 day courses to really give us a good start. But, you know, the basis of motivational interviewing is probably not that, you know, complicated in some ways. And you can find lots of great videos about it on YouTube. And, you know, there are lots of great resources around. And it's really just a slight, you know, change in emphasis or frame of mind, I suppose. And once you kind of learn those few basic things, really the main thing is practicing. You know, the first few times that you do it, it sounds, you know, it feels quite awkward to you. But once you're kind of into the swing of it, it seems, you know, much more natural. So that's what I would say. Learn a few of the kind of basic principles, and then, you know, give it a go if you come across a patient who seems to have that ambivalence.
That's great. Thank you so much, Clem. Now, if we would just conclude this sort of motivational interviewing sort of topic, but actually bring back the panel, if I may, we will have probably around a few minutes to actually address some of the questions, which will be great. Well, it is, first of all, I think a question for David and Jane. If a nurse or doctor or allied health professional in the hospital, they started doing motivational interviewing, setting goals with the patients about getting them to the point of being able to be referred to a community dietitian or exercise physiologist or physiotherapist, for example, can we expect the community, allied health professional community, to be able to embed motivational interviewing and some of these behavioral strategies in their consultations in the community? And it's just a question for Jane and David to start off with.
I'm happy to start up if you want to have a moment to think, Jane. But from my perspective, I think, like, obviously if a cancer centre has that expertise, a dietitian, an exercise physiologist, physiotherapist embedded, that is so lucky and fantastic, and, you know, really great care to be able to be received. But a lot of hospitals don't have that support. And there's a lot of patients, you know, and the survival rate's going up. So there's more and more survivors. So we need to keep training the community, other health professionals, to be able to see these patients. You know, we can't have people keep coming back to the hospital ongoing, and then maybe they don't want to keep coming back to the hospital repeatedly to see another health professional. So I think we have to have trust in the community health professionals. There's more and more certifications and programs, and even just workshops just like this, I think, are really critical in upskilling our community. I think what's important is we need to have these cancer centers working alongside the community health professionals, you know, so there's community centers closer to where the patient lives, so it's convenient for them. So, like, to increase the likelihood that they will have a high adherence, I think is important. And to reduce the burden on maybe the one EP that's working in the hospital, they can't see all those patients. So I think that's really critical, that transition.
Yeah, thank you, David. Jane, you have been praised that you are a very polite patient. So good role play there, but that's probably just how polite you normally are. What are your thoughts to that question that we just asked?
Yeah, I agree with David. I think I know from our experience here, we're probably not as good as transitioning patients to the community sort of sector as we should be. We tend to hold on to patients for a while. But definitely, I've also worked in community health and community rehab in the past, and clinicians are generally experienced and have that really solid background in managing chronic diseases. So often community clinicians have better training in motivational interviewing than what we as acute clinicians have. So I think as acute clinicians, it's about sort of helping to set those goals that relate to survivorship, and then transferring to the community where they can really work with the patient to meet those goals.
Yeah, thank you, Jane. Clem, in 131120, you obviously have a huge referral responsibility. Can you perhaps comment a little bit about, for example, being a nurse, if we actually do motivational interviewing and engage in a change talk, inspiring people to change, and people actually then gone on to do the exercise programs or, seeing their dietitian. Can you comment a little bit about the follow-up requirement on your part? Do you see the role of following up and actually doing further motivational interviewing and engagement with those patients once they've been referred to services?
Look, I think a bit of both. Mostly, in 131120, we take a sort of non-case managed approach. And so we would have the initial conversation with someone, and we certainly can offer a call back or a couple of callbacks. If people have got multiple complex problems or they're quite emotionally distressed, we would often do that. But we also have other, I suppose so far they're mostly specific projects that we work on, where we would have ongoing follow-up and touch base with the patient 2 weeks down the track or a month down the track. How, we discussed these things, how have you gone with it, and, help them, keep their motivation up and come back onto track. So I guess there are, different contexts. And I think these skills that are part of motivational interviewing are really applicable to lots of different contexts, lots of different clinical contexts. So when I was first learning about motivational interviewing, I would probably sit down with a little cheat sheet in front of me on the desk or something, and I would think, okay, I'm going to do a motivational interviewing session now. Whereas now, some years down the track, I just find that oftentimes, when I'm having a conversation with someone and they're sort of resisting things, instead of kind of trying to convince them even harder and thinking up lots of things, I'll just take, some little motivational interviewing approach and build it into whichever conversation I'm having. And I think that's the thing. Once you've kind of practiced it up and you're familiar and you're confident with it, it just starts, it's another tool that you have in your practice that you can use when you need to.
Yeah, thank you, Clem. Now, one of the questions from the panelists, and we're going to come to you in a minute, Paul. It will be very good to hear from you, having heard about sort of the content that we've gone through. What will be the sort of advice that you will give to all the health professionals who are on the call? But before I do that, I'm just going to ask Clem, because there was one question around whether you would actually have different considerations when it comes to pediatric patients. Are there any nuances when it comes to motivational interviewing, was the question.
Yeah, I mean, again, I have worked with some pediatric patients, but not a great deal in my approach. But I think at the very basis, at the heart of motivational interviewing, it is patient-centered, and it is, respectful, and it is respectful of the patient's autonomy, and that no matter who the patient is, you can get a very positive reaction by that approach. Now, that doesn't mean to say that I would necessarily sit down and do a kind of full, formal session, but those kind of key skills I think would be appropriate to children, teenagers, geriatric patients, the whole gamut, that there is something to learn in motivational interviewing for all our patient populations.
Yeah, great. Thank you, Clem. So Paul, having heard all these, what would be your number one advice? Because you certainly have been very grateful. You expressed your gratitude to the clinicians who looked after you. What would be your number one advice to health professionals overall that you think that, well, it will be helpful if they can actually provide this or provide that? What would be some of your suggestions?
I think obviously one size doesn't fit all. And there are so many variables, patients that are at different physical levels, they have different illnesses, different recovery rates. It's like there's a whole can of worms there. And it's obviously, it's difficult for clinicians to sort of, you can't put anyone in a box, so to speak. But I think just asking the patient what they would like, I think that's been discussed today, what they hope to get out of it, what do they want to improve or want to get back to in their life that they're struggling to do at the moment, or they used to do and they love doing it, and that's what they want to work towards. I think that's an important thing, and just not too much overwhelming information. That can be quite hard to deal with. Not too much too soon. And sometimes I'll say patients, as myself as a patient, we get a little bit lost and we don't know if we're struggling at one point, we don't know who to turn to. So I think having a backstop, if you want to call it that, or a go-to person, or a backup, or a fallback, if you want to put it that way, is extremely important. So if we're losing track, or we don't know what to do, we've got questions that we need to ask, we're worried about something, or we're struggling, I think a point of reference, say 13, 11, 20, like Clem mentioned, is extremely important, I think. And like I've mentioned, me living in a rural area, that creates its own sort of different aspect as well.
Yeah. Thank you, Paul. And certainly there have been comments in the chat room around the challenges that we have in rural remote areas, as well as the digital gap. Just a shout out as well to Cancer Council of Queensland, who has been trialling a telehealth cancer-related fatigue clinic program. And that's certainly something that the team is trying to look into, how that can be applied in a broader setting in collaboration with some of the other cancer councils. So that's something that hopefully we can actually bring forward as well. Now, in addition to Paul's advice, if I can just ask Jane, Clem and Dave to give us a 20-second sort of final sort of take-home message that you would really like people to have. And then it will draw to the close of today's session. So maybe, Clem, you've got your mic unmute, so you're ready.
Sure. So I think one thing that I'd like to highlight, and it's been touched on earlier in the thing, is how important small specific goals are rather than the big overall things. Because if people have small specific goals and they achieve them, that is really motivating for people. They feel like they've done something and then they can build another extra bit onto it. Whereas if you set really, really big, broad, ambitious goals and they don't get to those goals, then that's quite demotivating. So small, specific goals for most patients anyway.
Thank you, Clem. And I think one point that you raised that was very important too is the power of silence. Sometimes if people are not speaking, when you actually have a silent moment and say, people could actually really come on board and actually tell you more. So I think that was a very good wisdom from you. Jane, your take-home message.
My take-home message is, I mean, this webinar is really about weight management. However, I really try to take the focus off weight and really look at encouraging a focus on improvements in body composition, in diet quality and lifestyle change. So introducing exercise. So really not focusing on the scales and what the scales say. It's really what steps can we take to improve our lifestyle?
Yeah, thank you, Jane. That's a very good thought to leave with us. David.
Thanks, Ray. I just want to take a moment to reflect on how lucky we are in Australia to have Medicare fund these services to support lifestyle medicine. So I'm doing this tour in the US, and they are incredibly jealous of the fact that the government will pay for EPs and physios and dietitians. So we are in a unique and wonderful position to truly embed lifestyle medicine into cancer care. We're not there yet, but we have the opportunity. So we need to start with the clinicians and the nurses and the GPs and the people working in the hospitals who can then transition into community and get these wonderful Medicare benefits that are willing to pay for it. So we just need to keep that going and truly embed it. So I'm really excited to hopefully one day make this part of standard care.
Thank you, David. I think it's such a great thought that you have, that we need to sometimes really pause and really think through the resources that we have versus the resources that we do not have. I remember years ago when I went to the US, that's exactly the one thing that I've learned, although the purpose of the trip was to learn something from the people in the US, which of course we can, but the one biggest thing that I've learned is how lucky we are here in Australia and how advanced we are in providing quality patient care. But of course, there's more work to be done. That's why we're meeting here today. So we would like to then drawing to a final note to share with you some of the great things that the Australian Cancer Survivorship Centre, COSA, Cancer Council Victoria and CNSA are doing. And first of all, we would like to draw your attention to the clinical placement program, which is coordinated by the ACSC, and the fourth iteration of the program is to recruit allied health professionals and practice nurses to partake in cancer survivorship focused placement in Victoria. So do watch this space and do email in the ACSC placements at petermac.org if you need more information, but it's certainly a great resource. We are embarking on advertising the next webinar already. So please save the date. It will be held on the 13th of September, which will focus on the role of nurses in psychosexual health in cancer survivorship. So we will see you there. Make sure you put that into your diary right now. Use the QR code today to tell us how you feel the session has gone, what would have been helpful. We know that it is always difficult to sit through something for 90 minutes, but once again, I just would like you to join me to thank the panel in such an engaging discussion and all the sort of really important reflections from your experience, Paul. Very, very helpful to know all those experiences and to have the expertise of our panel today. Finally, I would just like to once again thank the collaborators from the Australian Cancer Survivorship Centre, COSA, CNSA, and Cancer Council Victoria. Now, as the chair of the survivorship group of COSA, it will be remiss of me not to encourage you to join us, join COSA, join the COSA survivorship group. As a group together, as a community together, we can work more synergistically together to learn from each other, but also advocate for better practices, better outcomes for our patients and our community. Finally, we'd just like to wish everyone to have a great weekend and goodbye for now, and we'll see you in September. Thank you.